Opioids and benzodiazepine tapering has always been a passion of mine. I currently work also at a telehealth company designed to help people taper off of benzodiazepines, opioids, and medications. Usually the way this conversation is framed is pro-opioids and anti-opioids, or pro-benzos and anti-benzos. The way I want to frame the conversation is just looking at it as pro-patient. In other words, what are the needs of the patient and how do we best serve those needs? So, of course, opioids are incredibly important, and we wouldn't be able to do many surgeries without opioids. Opioids alleviate suffering. And on the other end, opioids carry very significant risks, adverse side effects, and risks for addiction. All of that can be true simultaneously, but each patient is incredibly different in how those benefits and risks play out. So instead of looking at it simply from the perspective of benefits, from the perspective of risks, I would invite us just to simply look at it from each patient's individual life circumstance and scenario and how those benefits and risks play out in that situation. So the way I'm going to approach this is simply talking about opioids first, because a lot of the principles are the same. And then after that, going into how benzodiazepines are different in terms of tapering. Most guidelines will recommend starting at 10% monthly as a starting point for somebody that's opioid dependent. Somebody that's opioid naive or just been on opioids for weeks, that's a different story. But somebody that's been on opioids for months or more, months or years, that's going to be a long-term project to get them off of opioids. While you're doing that 10% reduction, you want to watch closely for signs of anxiety and depression, psychological distress, suicidal ideations. You want to watch signs for opioid use disorder. Are things progressively getting out of control with this slow taper? If it's a fast taper, you got a reason why things are going out of control. It's probably because if you're going down by 20, 30, 40%, it's probably simply due to the distress of the opioid withdrawal. Here's an interesting point in the DHHS guidelines, which is many of the tapering studies, when the tapering starts, used at least weekly follow-up. It doesn't necessarily mean you have to do that through the whole tapering journey, but it's good when, especially in the beginning, we're trying to figure out what's that dose reduction that they can tolerate to have closer follow-ups, and also periodically when the patient is struggling. There's a really good study that came out a few months back, which basically showed, I'm going to summarize it. The link is in the slide. For the sake of time, I'm just going to summarize it. If you've read about it or this is on your mind, we can certainly discuss it in the question and answer. But basically, long story short, they looked at opioid dose tapering. They looked at this in about 20,000 subjects, and they found that tapering was associated with a persistent risk of overdose, withdrawal, and mental health crises. And all of these were elevated up to 24 months after taper initiation. So they started to monitor people after about 12 months, and then they continued to monitor up to 24 months. So this was in tapering patients, quote unquote tapering patients. But then it's important to understand, what do they mean by tapering patients? So in the study, the mean reduction of tapering was 39% in the first 2 months. That's the mean. There was also people that were tapering at higher doses. That's not necessarily in line with the tapering guidelines that we discussed, which would be around 10% a month, and really guided by the patient's capacity to tolerate symptoms. You start at 10%, you decrease and increase based on what the patient is able to handle. This study seems to suggest that tapering has its risks. And then we have older studies that have consistently suggested that there's no real long-term benefit of chronic opioids proven. Of course, on an individual basis, you can absolutely state that there's long-term benefits for opioids. And I think we've sufficiently discussed that. And then there's also increased risks of serious harm. The point I'm trying to make is tapering too fast has its issues. Not tapering at all has its issues. But I want to really clearly clarify that this recent study, it's really would be considered tapering too fast if weighed against the tapering guidelines. So when it comes to the word tapering, it's always good to come to terms. The patient might have their own definition of tapering. You might broach the topic of tapering and they say, Doc, I tried that before. I can't taper. It's impossible. I tried to taper. I made a small reduction and I couldn't go to work for a week. I was writhing in pain, fetal position in bed all day for days. I can't taper. It's not possible. My pain's too much. And then you probe, you say, well, define taper. What happened? And this happens. We see this a lot. We actually go into it and they say, well, I went down by 30%, or I went down by 50%, or I went down by a large chunk. And then it's a good opportunity to say, well, we're not talking about that. We're talking about something much smaller, like 10% a month as a starting point and going from there. Benzodiazepines, also tapering them, follow similar guidelines. The main differences I'll mention are these three. One is that withdrawal obviously looks different with benzodiazepine withdrawal. Benzodiazepines target anxiety and insomnia, whereas opiates obviously target pain. A common reason for benzodiazepines being prescribed is actually chronic pain due to Medicare data in some studies. And the withdrawal for benzodiazepines looks different. Forget about the symptoms for a moment. The symptoms are different. The length of time is the really important part in distinction. Benzodiazepine withdrawal can be protracted. It can last for weeks to months to sometimes even longer than that in certain cases. And the confusing part about this is that benzodiazepine withdrawal can happen, let's say, weeks to months, and also be interspersed with periods of feeling completely normal. So you have patients that the timeline fits for them to, they don't have any symptoms, then benzos are, let's say, abruptly discontinued. They have these significant withdrawal symptoms. They last for weeks or maybe longer. And then they have this period of like a week where they feel normal, or days where they feel normal. And then those symptoms come back and they're the same symptoms and they come back. And this leaves everybody sort of scratching their heads as to what happens. But this is a well-documented phenomenon in benzodiazepine withdrawal. And to really save these patients unnecessary and sort of ambiguous, really long neurologic, rheumatologic workups, it's good to just be aware that this phenomena exists and look at that timeline to see if it makes sense here for protracted withdrawal. So that's one common distinction about benzodiazepines. The withdrawal can be longer, where opioids, the withdrawal is more predictable, can peak in days and can start improving in days to weeks. The other distinguishing factor is the tapering. The second point is the tapering amount. So guidelines usually suggest about 5 to 10% every 2 to 4 weeks. This is based on the Ashton manual, which is linked below in this slide. That's not too different than opioids. Then the third thing I wanted to mention is CBT for anxiety. There's many studies that show that CBT for anxiety during a taper, or CBT for insomnia, or different types of CBT, usually anxiety and insomnia, cognitive behavioral therapy has been shown to really improve results in terms of tapering off of benzodiazepines and tapering off them more successfully. And again, the area is linked at the bottom. So I'm going to wrap up there and just leave some time for questions. Thanks, everyone. Does anybody have any questions?